Hi, I'm Christie Ballantyne, joining you from the Cardiometabolic Health Congress in Boston. And this morning we went over the late-breaking trials. I'm here with Bob Eckel and Keith Ferdinand. So much has happened in the last year. Wow. Particularly if we go back to the beginning of this meeting, the cardiometabolic field, and I guess it's cardio kidneys. The kidneys in there.
Kidneys in there.
Don't forget the liver too.
Oh yeah. So we got it. But it's been pretty incredible. So you want to hit some highlights, share with our audience a couple of the things, and I guess we'll maybe go in the order. Keith, you went first.
Yeah.
A lot happening in hypertension.
It happened very quickly because for many years I had to kind of look for something. The FDA approved a new drug, aprocitentan. It's an endothelin antagonist. It's a vasoconstrictor that it blocks, and that's there. Renal nerve denervation has been now approved. There are two. There's a third one that's on the market, not yet, but it may get there. And I looked at just the population basis of controlling blood pressure. I mentioned how cardiovascular mortality was going up. And I said that although there are new devices and there are new tools, we need to control blood pressure, the most prevalent and potent risk factor.
You know, I think that's something that came up, talked about the perspective. I mean, it's really exciting what's happening with imaging and atherosclerosis and AI and everything else. But, we know the foundational is going to be lifestyle. But the other one, Keith, you point out is that, we've got some inexpensive, good antihypertensive drugs. We know that combination therapy works. But the numbers, they're not going in the right direction, are they?
I think what's happening is we got laissez-faire. We just didn't pay much attention. The last hypertension guidelines, high blood pressure is what they actually are called, was 2017. So it got off the radar. No new drugs. Renal nerve denervation was not there. So maybe new investigational drugs, renal denervation will put more emphasis on the importance of blood pressure control, but I don't think that's the answer. The answer is to use what we have.
Yeah.
Keith, I think there's another concept that relates to cardiometabolic medicine as a whole. It's therapeutic inertia. I mean, if George were still here with us, he'd say maybe when you were starting antihypertensive therapy, it should be 2 drugs, not 1. And I know you've been...
I agree with that.
Yeah. So that's true in diabetes, also true in lipids to some extent, too. Yeah.
So, and one, I think, really important point, I think people get it now. You ask somebody, what's the optimal LDL? I don't know anyone who's going to say it's over 100. I mean, most people are going to say it's under 70. A lot of the cardiologists will say it's, under 50. But I see with blood pressure, I don't see the same people getting it that look, lower is better. You talked about an important study. I mean, Sprint came out, and it seemed like people were just a big yawn about that. And then you mentioned the Chinese study today, but what's optimal?
Optimal blood pressure, systolic, about 115. Once you get above that, cardiovascular risk goes up. The Chinese study, most people don't know, it's called ESPRIT. It was a big study, 11,000 persons, and it did include people with diabetes, about 40%. And they showed that a goal of less than 120 versus 140, similar to Sprint, but now including diabetes, shows a benefit, and it included total mortality. The dirty little secret, not much we do in medicine improves total mortality.
And Sprint stopped for mortality also.
Yeah, it sure did.
So hypertension, and a really important point about what's an optimal blood pressure when people want to know what's optimal for them. So Bob, you talked about a lot going on in the area of obesity and diabetes today. Why don't you share some of those highlights?
Obesity, one of the things maybe I'm most excited about is the fact that the Lancet Commission, an effort over 2 years now, has been accepted for publication in Lancet Diabetes and Endocrinology. This has been a global effort from every part of the world looking at how we define obesity, and that seems simple. And I can summarize to say if a BMI is 35 or 40, somebody's got too much body fat. But now in these more intermediate ranges, sometimes it's called overweight, sometimes called obese, sometimes called normal weight, based on certain regions of the world. Ultimately, we're defining it the need to go beyond BMI with additional measurements of body fat, including body fat distribution. We all know that abdominal or visceral or splenic increases in adipose tissue is much more harmful metabolically and in terms of cardiovascular disease risk and diabetes risk. So I think this is going to be a major step forward where we're defining obesity as not a disease, but it's a medical condition we call preclinical obesity, and clinical obesity will be defining obesity when the amount of excess body fat is impacting a disease we recognize, like type 2 diabetes, for instance.
Well, but we also have hypertension, hyperlipidemia. I mean, obesity influences all of these metabolic factors, the kidney. But therapeutics has really taken off.
It has. I mentioned a couple of studies. I mentioned SELECT, which looked at a combination of outcomes which related to differences between HFrEF and HFpEF in terms of semaglutide at maximum dose. People titrated up, most of them, Keith, but not all of them, titrated it up to 2.4 milligrams. And the benefit was there, particularly in people with existing heart failure versus those without heart failure. But moreover, I think the HFrEF population seemed to respond a little bit better than the HFpEF population. So this is a clinical trial showing that in obesity, in the absence of diabetes, that a weight loss drug has a major impact on outcomes. And that was true for all-cause mortality, in addition for HFrEF more than HFpEF. The other trial I mentioned was tirzepatide in obstructive sleep apnea. That's a major problem. And this was measured by apnea-hypopnea indices. And that's how many events you have per hour over a 24-hour period of measurement. And not only was there a lot of weight loss, but ultimately there was a major improvement in AHIs, meaning the apnea-hypopnea index, which is the way sleep science is really assessed clinically. So these are two major effects of weight reduction, both on cardiovascular disease events and related cardiovascular disease death and all-cause mortality in HFrEF particularly, and also a benefit in obstructive sleep apnea. So these are major advances related to this new class of drugs, which maybe shouldn't be in the drinking water yet because they're not orally available, except for semaglutide does come orally, but for the most part, these trials are done with the injectable, not the oral form.
So really pretty spectacular data. In terms of lipids, no new approvals. Keith, hypertension has beaten us now. We used to be this, we don't have these two very promising agents that have going through the approval process at the FDA, both targeting ApoC3, antisense oligonucleotide, olezarsen, small interfering RNA molecule, plozasiran, both of them showing in people with FCS very good reductions in triglycerides and promising reductions in terms of pancreatitis, although one of the trials was a secondary endpoint with it. But and there's a lot more in the pipeline with the PCSK9s, CETPs, gene editing. I mean, there's a lot happening there. LPA on the horizon. I shouldn't say that. It's the name of one of the trials, but it's a lot moving. Nothing quite ready yet to give to our patients, but it's still an exciting area with a lot happening for it.
Well, a concept that comes across with the lipid-altering therapy, I think the LDL lowering is clearly well established, and we have other ways of doing that these days. But the triglyceride relationship to cardiovascular disease is still a little bit problematic, and I think the whole issue of it's maybe not the triglycerides themselves that are causative, but more the particle that carries them. Your thoughts about
this is the issue that what's really looked at is the remnant cholesterol. Now, in terms of. And that was the decision in terms of going forward. There is an outcomes trial that's going to be done, but it was based upon people having high levels of remnant cholesterol, because you do reduce these. It's the cholesterol probably in those particles. They're ApoB containing particles. But anyway, exciting areas like and LPA still, although it's a very important thing, and it's one thing that we had a paper with Chadi and Adomi looking at population distributed risk, because it's in terms of disparities, you're going to have a lot more high LPAs in people who are black
and South Asian,
and so this is potentially an important area. Not much screening going on. We don't have the treatments yet, but we do know that even just healthy lifestyles, statins, these things are effective also.
I look forward to 2025. We may not have any new data in terms of outcomes, but maybe something will have been stopped with a Highline report that will say maybe so.
We hope.
But still, it's a risk factor. It's not a risk enhancer. That's what the old guideline said.
Yeah.
And I would want to know, if I had a small car and I was going around a mountain road and there was a tractor trailer coming around the other way, I want to know that.
So it is a risk factor. All right, but so there was a lot covered. One of the exciting things to me about this, this session is to in one session we get such an update over the field, and remarkably, every year there's more.
That's why I come to meet you and to meet you. You get to see your colleagues, different fields all over the country.
So much is going on, and so we hope that you join us next year. Next year will be our 20th anniversary on this, October 23rd to 25th in Boston. It's going to be a spectacular meeting.
You know, before we close, the whole issue of new sensors, new pumps, that came up, and there's some advances going on there. The Eversense now having a year approval by the FDA is a major step.
That's pretty
sensing.
spectacular.
That's a nice piece of new information. The other thing she mentioned is resmetirom, this new treatment for MASH, so-called NASH, or fatty liver disease. And that looks promising, although the data are not they don't knock your socks off the data, but they do look promising in terms of another option to modify the natural history of fatty liver disease. So that was mentioned in the slides that I presented this morning. So
yeah, and one thing I do want us to mention is that we had a tribute to George Backwards, and I see what's now they talk about cardio, kidney, access, and George was really, I think, one of the leaders. Keith, you also, in terms of hypertension, effects on the kidney and the heart with it, and so. And we do have a program for the George Backwards Scholars. We got some great applicants for that this year. And so his memory lives on with us. But make sure to come next year. There's a lot happening every year, and it's a terrific meeting.